So hello, my name is Christen MacKorell. I am a PA student in my clinical year at Gardner-Webb University, and together with Elyse, we have completed our project on addressing the perceived barriers to the utilization of PAs in OB-GYN practices across the state of North Carolina. A lot of our project was driven from the constituent organization that physicians have through ACOG, as they have strived to develop a way to implement more collaborative care. Following the demands, they have created and implemented a task force that was interprofessional to address issues of efficiency, quality, and value in team-based care models. And out of that study, they named PA specifically as playing an integral role in the women's healthcare team by adding and generating revenue for the practice, increasing patient satisfaction scores, and improving patient outcomes. So coupled with the recommendations put out by ACOG, as well as their estimation of an OB-GYN shortage greater than 9,000 by the year 2030, we were a little surprised to see that North Carolina was not implementing PAs in the same ways that other states across the country have used to help with women's health. So accordingly, we decided that our project should kind of focus on that, with North Carolina being the birthplace of the PA profession and home to more than 11 PA programs. We decided to determine what barriers or perceived barriers there were to incorporating PAs in the women's healthcare team. To do so, we thought we would work directly with the physicians, so we collaborated and created a study with SurveyMonkey to send out to current OB-GYN physicians that are members of the North Carolina Medical Society with a brief description of our project, what we hope to accomplish, and our survey. We had less than a 20% response rate, so a small sampling, but we do feel like it generated very relevant data to where we were at as a state.
Thanks. So my name's Elyse Watkins, and I'm a PA. I'm a clinical practicing PA, although right now I'm currently in academic medicine. And I do have to give a disclaimer that I've worked in OB-GYN for most of my career, unfortunately not in North Carolina. So I moved here 2 years ago, and Christen and I became kindred spirits when we realized that the state of PA utilization here wasn't quite as robust as it is in other states. So our results, I'm going to go over just the highlights. This one was pretty reassuring that most physicians we surveyed would be likely to consider to use a PA in their practice. But what was a little bit concerning was the number who were not likely to even consider using a PA in their OB-GYN practice. Have you had a PA in your OB-GYN practice? Clearly, most physicians here have not. Question number 3 was, how likely would you be to hire a PA in your OB-GYN practice if they had completed a fellowship? And I was really reassured by this data because that number jumped up from about 45% who would consider a PA in their practice to about 60%. So the next question was, what would be the biggest obstacle? And this was a free text question. It was really interesting. We got pages and pages and pages of free text. Some of it was a little discouraging. A lot of it was almost insulting, to be perfectly honest with you. But the cogent points were that a lot of OB-GYNs feel that most PAs are not trained adequately in women's health. A lot of us have 5 or 6 weeks rotations in women's health, and some of us didn't have experience in labor and deliveries on our end previously. And so this was a strong perceived barrier to using PAs. Another question was the biggest obstacle that you would see in hiring a PA and to utilize them accordingly. Again, the same theme about experience in women's health specifically. And so question 5, we offered up any further comments and really trying to tease out what people were thinking at this point. But again, the same type of theme came through. Lack of experience. If PAs could actually do deliveries, can PAs do deliveries? This concern that PAs have no specialized training. I will say, for those of you who are interested, PAs can do deliveries as long as the supervising physician delegates that and the hospital system allows that to occur. Lots of hospital systems around the country, Massachusetts, New York, and California, are doing this with tremendous success. So given this information, what do we do next?
So we realized that we needed to have a platform or a voice to communicate with physicians adequately and accurately the information that would be best utilized whenever it came for them to decide whether or not to use a PA in their practice. So we began a conversation with APAOG, which is the constituent organization for PAs who work in obstetrics and gynecology offices, to develop a podcast or a web resource for physicians. And whenever we were talking about this, we kind of envisioned it being a dialogue between a current physician who is utilizing a PA in their OB-GYN practice and a PA. That way that they could have an understanding of the common questions and concerns that the physicians have, and that they could be addressed by both sides to dispel any misconceptions and to discuss the benefits of utilizing the PA in their practice.
So Christen and I got together and talked about this idea of a fellowship model. If a lot of the feedback we're receiving from our physician partners are that PAs need more training in OB-GYN specifically, let's develop an actual postgraduate fellowship. This is not a novel idea because this is being used, again, at other large hospital systems and academic medical centers across the country. So I would love to be able to take absolute responsibility and say this was my idea and this was Christen's, but this has been developed. The scope of practice of PAs is very broad. So we're trained in the generalist model, but we can also perform a lot of procedures, inpatient and outpatient. One of the ways PAs are used successfully in OB-GYN practices across the country is by having their PAs first assist in various surgeries. A lot of PAs will take calls so that instead of the OB-GYN at 3 a.m. having to rely on a RN/FA, they can call in their PA and actually bill for that. The fellowship model encourages PAs to continue knowledge in primary care medicine and in generalist medicine. As such, PAs are in a very, very prime role to increase the ability of the OB-GYN to build their practice because, for example, with the ASCCP changing guidelines for PAPs, so patients will come in only once every 3 years for an annual PAP. Instead, OB-GYNs can have patients come in every year, and the PA can address a lot of their chronic medical problems. Another part of the fellowship model, which we thought was really important for our physician partners to know, is that, number one, docs can earn CME by participating in this. And that the emphasis is going to be on developing these higher level skills that physicians seem to want from their PAs if they were to hire them. And so most fellowship models have PAs in a 1-year period of time perform over 200 vaginal deliveries and first assist in over 60 C-sections. In keeping with the model from other states and in a way that reflects an academic environment, there will be a didactic portion as well as a clinical. The didactic portion consists of daily rounds, lectures, journal clubs, MMRs, reading, simulation experiences, and then self-directed learning, which you can't see on that slide, but that's at the very bottom. The clinical portion of this obviously is experiential in that the PA will be following their physician partner and they will be trained on ultrasound, labor and delivery, both triage and actual delivery, surgical assisting, and then outpatient clinic work. And I do want to point out that the idea of this is not to replace the physician, but to really increase access for the patients, to free up the doc to do more of those higher level procedures. And quite frankly, docs are exhausted. So the other really good thing about this fellowship model is that the PA will be submitting an article to a peer-reviewed journal, and the doc can be a co-author on that. So the anticipated outcomes: enhanced access, increased profitability for the practice, and decreased malpractice claims. Any questions?